Thank you very much, Triana, for this very kind introduction. I will talk about qualitative endoscopy and IBD, and probably this will be the less fancy talk of the afternoon. But the advantage here is that probably the patient will not bleed here. So we'll talk about endoscopy in patients with IBD. And before we start talking about quality, we should first look whether there are already guidelines for quality in care for patients with IBD. And they have been published last year. So this is an echo statement, a position paper, where we have an overview of all the quality outcome indicators for patients with IBD. So in total, there were more than 100 statements included in this position paper. And if we focus on the ones that are interesting for the endoscopist in IBD, then you see typically that this is subdivided in 3 groups, so structure, process, and outcome quality indicators. But you see there are not that much quality indicators that have been established. First of all, you have structure quality indicator, and the most important here, and I think this is already a message, that if you do endoscopy in IBD, I think, and you are with multiple gastroenterologists in your group, you should really try to have special or gastroenterologists with special focus on that topic. So as an identified endoscopist with a focus on IBD. Further than concerning the process quality indicators, you see them here, the list of them, and I will discuss them during this talk. And also, there was only one quality outcome indicator that was identified in this position paper, and this is on the timing of the endoscopy, which will also be touched during this talk. So, but what exactly is quality for IBD endoscopy, and what does influence the quality of IBD endoscopy? And I think we can identify 5 subgroups of items that that influence the quality of the IBD endoscopy. And then the biopsies, if you take biopsies in patients with IBD, there's often a discussion on where and what type of biopsy you should take. And nowadays also histological remission, certainly in ulcerative colitis, is becoming one of the treatment targets in a treat-to-target strategy. So it's important that we know where to take the biopsies. So we have done a study in Leuven where we looked at the ideal location of the biopsies for ulcerative colitis, assuming that we have a homogeneous distribution of the disease activity also on a histological level. This is something that is assumed, but that never have been proven. And in this study, we took biopsies at 3 levels in the left colon, and in each segment, we took in 3 regions of interest a biopsy, and then compared the histological scoring of these 3 regions of interest in each segment. And there we saw that there was a quite homogeneous distribution of the histological inflammation, and that the variability of the histological scoring there was very low comparing the 3 regions of interest in each segment. So we can confirm here the assumption that the distribution of the histological disease activity in ulcerative colitis is homogeneous, and so it doesn't really matter where you take the biopsies. The most important thing is that you take biopsies in a continuous inflamed area, macroscopically continuous inflamed area, and then this is representative for the whole segment. For Crohn's disease, it's a little bit more complex because the distribution is different. Also for this, we have done a study in Bonheden in collaboration with the University of Amsterdam and Ljubljana, and there we have compared also 3 regions of interest next to an ulcer in patients with Crohn's disease. As you can see here, we took biopsies at the border of the ulcer, 1 open forceps from the border, and then 3 open forcepses from the border. And there we saw that the biopsy taken at the border of the ulcer is the one that is most representative for the disease activity. So this is absolutely also the place where you should take the biopsies in patients with Crohn's disease.
Right, so you really want to clean this here and make sure that you inspect this thoroughly. And again, there you can see all the small pseudopolyps here. You see them?
Yeah. You can see them beautifully. Can you see them in?
We see that perfectly. Can you hear Jeroen? He will ask something.
Yes.
Yeah, I just have a quick question. So you've shown the scarification and the pseudopolyps. Which one of the two triggers you most to have a more closer look? Are you more afraid of the scars or the pseudopolyps, or?
Absolutely anything in between those pseudopolyps. So that's I think that may be a beginner's mistake. If you start focusing only on this, it's very nice because you get excited and say, "Oh, look, wow, nice." But actually, you should indeed look in between the polyps. So it's more the areas that are scarred where you really want to look, right? So the scars that trigger me more to look carefully, and then you have here these dark areas. And especially also the pseudopolyps that are a little smaller. So these long stalk things, and even if you start rinsing, they're like little sausages swimming, or they're even bridged. This is a sign where you don't even have to look at the pit pattern. But anything that is more stuck to the wall, there you have a closer look, and it's really done instantaneously, right? You see it's round, and you go on. And sometimes you really have a forest of these pseudopolyps where you have to look.
In our existing scoring systems. So he's been able to show in a few publications now that these RD, or red density scores, actually have a very good correlation with conventional endoscopic scores, as well as histologic indices. And over time, we're expecting to see more and more that these more granular measurements may, in fact, have the potential to surpass conventional scoring in terms of their ability to predict outcomes. So in conclusion here, it's pretty clear that right now, artificial intelligence is already improving the standardization, the reproducibility, the accuracy, and the efficiency of assessing endoscopic activity in IBD. So this has been a real laggard in our in the quality of our endoscopies, whether you're an expert or less experienced in inflammatory bowel disease, and these technologies are going to make a big impact in improving that. In addition, we think these new video analysis techniques are going to help improve the precision of IBD assessments and allow us to go beyond the existing capabilities of our current scoring systems.
It's a pity that we cannot ask you the questions, but we have Peter. So he's also an expert in artificial intelligence in IBD patients. And so I do have a question for you. So in general, Peter, for people like me not knowing about this technique, where do you see, in which situations do you see a real added value for our IBD patients?
Well, I think you should look at it in a broader perspective, and what has been shown here and what the focus was mainly up to now was focusing on reproducing what we as humans can do. This is a big step forward, and it is the first step forward, because in that way we can more in an objective way, in a standardized way, do the evaluation based on the existing scorings. But the disadvantage there is also that you have you take also into account all shortcomings of these existing scores. And I think if we really want to have an added value, you should also go a step further than doing what we do now and look further to prediction of disease course over time.